Thank you so much, sir. First of all, I'd like to thank you, sir, for giving me the opportunity, and thanks to AIOC. Uh, I'm going to discuss about the endoscopic and laser DCR. Uh, After the proper knowing the anatomy and case selection, and the step-by-step DCR will be discussed by the Sudhir, sir. So, uh, as we know, so basically DCR creates a surgical opening between the lacrimal sac and the nasal mucosa, just proceeds to the anterior lacrimal crest. But why there's a need of so many techniques? Even though there is the external DCR is proven and success rate is high. Why there is a need of endoscopic and laser DCR? Because some different patients are presented with a different clinical scenario with a different problem. Just to see here, the patient with a young lady presented with the watering and mucoid discharge, and she wants cosmetic as well as resolve the problem without any further complication. Another young girl presented with the mucosis, insisted mucocil, and she also want good result without any cosmetic disfiguration or a scar on face. And another old female presented to us with the nasal obstruction with systemic comorbidity. And other young child presented bilateral insisted mucocil, and another patient is presented with the acute dacryocystitis, periseptal cellulitis. So different cases have different problem, and we have to think according to the problems. So that's why there is a need of multiple or different approach for the management. As initially, just we transnasal DCR was first described by Cadwell in 1893, but it was not gained popularity due to the poor illumination of the nasal cavity and intraoperative bleeding. But nowadays, advancement of the newer techniques and technology, these techniques are gaining widely accepted and doing most of the people are doing. And laser DCR was first described in 1990s by Masaru et al. And there was so many paper published with the different results. So here I am going to discuss about the lasers used in the endonasal DCR. There are so many lasers, that is the potassium titanite phosphate, aluminum YAG laser, diode laser, argon laser, convex laser, but the most commonly used laser was the KFT and diode laser. So diode laser property of diode laser is work as a contact mode and create and evaporate and coagulate at the site of the contact only. And it has the different fiber optics, 200, 400, 600 microns, and because the smaller the size of the diameter of the diode laser has the more energy power of the tips. So commonly 400 microns diameter diode, optic fiber were used, and it needed a metal guided wire, because if we deliver the energy, it causes the burn of the punctum and lead and canaliculi. That's why metal guide wire were used to prevent the iatrogenic complications. So power was used was 8 to 10 watts. It acts fast and deep incision, and pulse was 50 millisecond. It would be the gentle, and it's help in gentle and precise incision. Above that power, it lead to the iatrogenic burn to the canaliculi and the mucosa. And proper case selection is very important while doing endoscopic or any DCR. Generally, we avoid DNS. Medial terminate hypertrophy, canacular blockage, or acute dacryocystitis should be avoided in cases of endoscopic or laser DCR. Pre-operative preparation and techniques are the before going to the any surgery. Local anesthesia should be proper, so that surgeon and patient should feel comfortable. And patient place supine position at 50 degree, and appropriate laser safety should be used. Just to see the proper anesthesia, we should block the at least 4 block nerve, infraorbital nerve, anterior spinal nerve, intertrochlear nerve, and dorsal nerve should be blocked. And then after proper dilatation of the punctum, we should also use upper punctum, because if any, we should not disturb the lower punctum for the DCR, any kind of DCR probing or dilatation. So after the dilatation of the upper punctum, a probe is or optic fiber is introduced through the canaliculi and reach up to the bone, and once you feel the hardness, then you start the laser to create opening and make the ostium at the bone and create the opening in the mucosa. Just to see here, and it also should be visualized endoscopically, so that you should be ensured that the opening should be in front of the common canaliculi, and it should not in front of the medial concha. That's why and if you pierce the mucosa, then laser probes should not touch the septum. So otherwise, it lead to the burn and later on the fibrosis. After the osteostomy, silicone tube was implanted by bicannular silicone tube was implanted, and it was secured. And MMC, mitomycin C, applied for further any fibrosis. And should be keep in mind, the tube should be removed after the 4 weeks. Don't lift the tube more than that, otherwise it lead to the sometimes canalicular injury, punctal injury. So the advantage of and every surgery has the advantage and disadvantage. Advantage should be performed on the local anesthesia, can be performed in the patient is on anticoagulant, and shorter operative time, more effective hemostasis and low hemorrhage rate can be occur, and it should be done in case of failed cases. And complication and disadvantage, it sometimes the low success rate, high cost, and laser precaution is required. So indication of the endoscopic and laser DCR is if there is a nasolacrimal duct obstruction. In cases of failed DCR, patient is unfit for general anesthesia, then we can go for, and patient is on anticoagulant therapy. So complication is either if there contraindication if patient is on if suspected tumor, AIOC rheumatosis, if there is a thick or post traumatic cases, or then is there lacrimal passage pathology, it should not be done. So post-op care should be taken: oral antibiotic, anti-inflammatory, nasal decongestant, topical antibiotic, anti-steroid eye drops should be given. Wash of the nasal cavity with saline should be done. Repeated syringing sometimes may required. Complication and failure. Every surgery have its own complication and failure rate. So in laser surgery, it causes stenosis, granuloma formation. There is a synechia with the nasal mucosa. Sometimes stent migration, and if there is the opening is not on the proper way, then some syndrome can occur. And sometimes cutaneous fistula can occur, and a small failure is due to the small ostium and inappropriate site of osteotomy or canalicular occlusion may lead to the cause of failure. So conclude that endoscopic or laser DCR should be preferred in young female patient. They are really better for the cosmesis. It should be performed under the if there is a failed cases, and of course it's patient on anticoagulant medication should be done. Thank you so much, sir, for
thank you,
opportunity.
thank you, Dr. GYAN, for that direct